to start. I'm going to start the slideshow for you guys, and I hope that we have time for questions. If you have any questions, put them on the chat. I will try to answer them I will leave some time to answer questions at the end of the presentation. If you have a question that cannot wait until the end of the chat, please raise your hand. I'll also try to pause in between slides so we can address anything that is more urgent. So this is actually the first part of our, we talking about different diagnoses through this educational program. This is the first part where we're going to of a focus change into treatment. So we're going to be talking this month about how is treatment addressed with medication, and then in the following months we will be talking about how treatment is addressed with therapeutic interventions. And I will, it's very cursory and you know, go over a lot of things. These might not apply to your family members necessarily, but I hope that it gives you an idea of how the combination of different treatment approaches in a more holistic way works better than just one particular approach. The one thing that I would start before, I wish I had like a blackboard here or something that I can actually like draw for you, because it gives you a nice visual, but I'll try to start this before I start the slide presentation by telling you that medication management is one part of the interventions that we introduce for basically brain pathway change. So when we're treating mental illness, we are basically trying to teach the brain to function differently. And there are like two levels of teaching that brain to function differently. The level that we're going to learn about today is the micro level. So medications act and work for the client at the synaptic space, and I'll show you that in a second. And they therefore change or help neurotransmission for a more efficient message. Whereas therapy works at the macro level. And the therapy is the one that creates new neural pathways, new ways of thinking, if you want to, you know, put in other words. Now, these new ways of thinking are much easier to learn when you have the right messengers. If the messengers are not working, it's not impossible, but it's a lot more difficult to create those new neural pathways, to use new ways to understand reality. So just to frame ourselves, we're learning today about the micro level. What are those messengers that are needed, and how medications help us be more efficient with our messages. Okay. So medication management, obviously there are a lot of medications that can treat different mental disorders. This is also important because medications are not assigned by diagnosis, but they're assigned by symptoms. So you're going to hear sometimes, and you might have the experience with your family member, right? My family member has been diagnosed with depression, and the psychiatrist is suggesting an antipsychotic, and but my family member is not psychotic. But there might be some neurotransmitter that antipsychotic makes work better, and therefore will make the messages better. Or you might have someone that I think I had a conversation with someone, you know, what's the difference in between bipolar and schizoaffective? And a lot of people have some question. The main difference is what symptom is primary, but you still have two kinds of symptoms. You have symptoms of mood and symptoms of thought disorder, mood disorder and thought disorder. Therefore, you need something for your mood and you need something for your thinking. And that, you know, means that a person with different diagnoses cannot be on exactly the same medications because we're addressing the symptoms. It's usually, again, as I was saying before, it's usually used with a combination of other treatment approaches. And that's important because medication on its own doesn't do anything but fine-tune our messengers. We can send better messages, but if we're not actually working on having those better messages, then change will be minimal. There'll be some change, but the change that you are sometimes thinking, oh, you know, they put my family member on an antidepressant and they're still having thoughts of despair. Yes, that is possible. The serotonin is there, but they still have to learn different ways of thinking. And the other thing that is important is that it may take trial and error, and this is very, very important because people get discouraged before you find the most effective medication, and also with fewest side effects. One of the main reasons why our family members stop taking meds, it's because of the side effects, right? I'm sorry, I have 25 dogs in my house. Okay, they're okay now. So, you know, sometimes the medication, it's working well for the psychiatric symptom, and yet, you know, the side effect might be too difficult to tolerate, and you have to put yourself sometimes in the place of your family member and realize that you know, it's not worth having that person experience those side effects because of quality of life. And if the quality of life is not worth taking the med, they're gonna decide not to take it. So it's important to explore side effects, as providers, we do pay attention to side effects. We do want to minimize them, and we do want to address them if the person decides to take the medication in spite of. The other important thing is brains are different, and we still don't know everything about brains, especially at the molecular level, which is where medications work at. So there might be a slight nuance about the neuron and how the synapses works on that particular neuron that might make one medication work better than the other, or might need a potentiation effect from another medication. So I guess the short story of this is, do not get discouraged if the first medication or the second medication doesn't work. It's a trial and error sort of business. And also, again, I would say this through this presentation many times, medication, it's not everything. It's not enough that you found the right medication, then you have to do the right therapeutic work for things to work ideally. And the next point is, clients should be educated about the mechanisms of actions. I'm actually going to give you pretty much the same education that we give our clients at the program. This is certainly not medical school, but it's a good illustration of how medications work, so that they know what that medication is doing in their brain, and they know why it's valuable to consider the different medications. And again, like I was telling you before, the clients are ultimately the ones that should judge, you know, how to adjust the medication and if it's helping them or not. Severe side effects could be as impairing sometimes as not taking the medication. So sometimes, you know, we have to hear our family member, we have to hear our clients and adjust things so that they can have a valuable, meaningful life that they enjoy living, and therefore they're not going to stop their medications or stop doing what they're doing for a better life. And then, of course, psychiatric drugs are psychoactive substances, so we also have to be careful with what they do in the brain, and some of them are more addictive than others, but there's always, you know, that part of that. We gotta pay attention of what's going on when we're taking medications. Okay, so this is a synaptic transmission. I love this picture because it tells you pretty much how neurons communicate. And if you've taken biology class, maybe you remember this little drawing. But basically, neurons send messages to the next neuron through neurotransmitters. So they have an axon where it says axon terminal. That's the neuron that is transmitting the message and is releasing a certain neurotransmitter to the intersynaptic space. It's important to have enough of that neurotransmitter in that intersynaptic space, because then the other neuron, the receiving neuron, can't have enough of that neurotransmitter to make sense of the message. And then that receiving neuron has a receptor, and that receptor is particular to that neurotransmitter. So there's a lot of different kinds of receptors in the receiving neuron, and those receptors are very, very particular. Imagine like it's like a key, right? So the key only matches the right lock. If you don't have the right lock, the key is not going to open it. So think about the receptor as the lock and as the neurotransmitter as the key. If the receptor is misshaped or the receptor has been affected, for example, substance abuse can change the shape of the receptor. If the receptor is not matching the key anymore, that might create a problem. Also, if you don't have enough keys for the receptors, that's another reason why you might not have good transmission. So how do medications work in this space? They can do three things. They can increase the amount of neurotransmitter in the synaptic space. Think about SSRIs, the medications for depression. What SSRIs do is, and I do this drawing for our clients as well, if you think there are the first neuron, the neuron that is sending the message, is not sending out enough serotonin, which is the neuron that transmits well-being messages. And there is not enough serotonin in the synaptic space. Imagine that the SSRI will send a little bolt for those serotonin things. And that little bolt will keep the serotonin floating on that space enough for the other neuron to use it. So that is increasing the amount of the neurotransmitter in the synaptic space. That SSRI does not affect the production of serotonin and does not affect the receptor of serotonin. It simply affects the fact that you're now going to have more serotonin, more keys to open the well-being door that is on the other neuron. They can block the receptors for certain neurotransmitters, and that's what the antipsychotics do. So if you think about the main neurotransmitter that works on psychotic symptoms, you're talking about dopamine. And dopamine, in large quantities, it's a feel-good, think good, do too much of everything kind of neuron. That's also associated with mania. So like if you've ever experienced psychosis, someone with psychosis has too many thoughts, too many behaviors, too much going on in their brain. So the antipsychotic will close the door, will put some sort of like tape in the lock so that the keys cannot go in, and decrease the number of messages so that thinking can be clear, so that people can sleep, so that people can be organized with their thoughts. So antipsychotics are neurotransmitter blockers. They close the door, like basically saying, we have too much of these, enough. We can't handle these many messages. The side effects of taking, some of you might know, the side effect of taking antipsychotics is primarily what we call akathisia or EPS, which is it's basically Parkinsonian-like symptoms, right? You'll see people pacing or people having some involuntary movements, and that is because too little dopamine in your synaptic space, too little dopamine for transmission is actually the cause of Parkinson's. But people with Parkinson's disease actually takes medication to increase the amount of dopamine because they need more of it. So having Parkinsonian symptoms as a side effect doesn't mean that the antipsychotic is not working, but maybe the dose is not right. So that's good to know, because if I observe my family member or my family member says, my neck's stiff or I can't stop moving, that might be a sign that we have a little too much of a dose but maybe a decrease in the dose will still work, will reduce the side effects, but still have the effect of blocking that door so that there's no disorganization. And then another way that medications work on this intersynaptic space is they inhibit the action of a certain neurotransmitter. And by that, I mean, basically, they don't work on the lock, they work on the key, right? They might like slightly change the shape of the key, so the key doesn't work on the lock anymore. And the benzodiazepines are a good example of this. They basically work in GABA neurotransmission, which is, the GABA normally will transmit anxiety-related, fight-flight kind of related messages. So benzodiazepines basically kind of mess with the key so that anxiety message does not work anymore, or does not work as much so the person can tolerate that anxiety. Okay. Treatment. So again, I'm going to be a little repetitive because I want to make this point across. Recovery is a result of coordinated use of various treatment modalities aimed to improve the person's quality of life. And that's very important because although medications are super important, alone, they only do so much. And when we talk medications, we have to always consider quality of life for our family member. So again, holistic approach is the best approach. Research lately, it's more and more supporting this kind of approach with different modalities. And I think if for whoever was in the last educational meeting, and we'll talk more about that next time we meet, there's all the thought about top-down approaches, which basically means therapy using your frontal lobe, using your thinking brain, and bottom-up approaches, which are therapy using your more primitive brain to break down the cycle and to create new neural pathways. People respond to medication in different ways, and that's also important. The degree of success with different medications will depend on the idiosyncrasy of the person, and you will not know until you try. In other words, you might have had, someone might have told you, oh, my family member went in this medication and they did super well. And then your son or daughter goes into the same medication and the result is not as good. And you're like, what's going on? It's just a different person. And, for all these categories of drugs, there are different drugs that are slightly different because of that reason. I can tell you, for example, if you look at all the SSRIs, psychiatrists can be very particular about what they pick for what person. An older SSRI like Luvox or Prozac will probably work for someone that has depression with a lot of anxiety or has an OCD component to their depression. Whereas a newer SSRI like Lexapro will be used for depression itself. And then the SNRIs, which is another kind of antidepressant, are usually used for more like treatment-resistant depression for people that has tried many things and have not worked. And you had a psychiatrist friend that used to call Effexor rocket fuel, because if nothing worked, the Effexor will like mobilize the person. And I'm not sure that will work for everyone again, but it is a second sort of step medication that usually psychiatrists will tend to use something like Lexapro before they go into Effexor or Paxil or something more of an SNRI. So again, every person is different, and remember that we're not now talking about diagnosis, but specific symptoms. That's why the psychiatrist does an assessment and does really look into what symptoms are we addressing, and they're very, very specific about that to pick the medication that they would recommend. It often takes time for medications to be effective. There's some medications that work right away and you can notice the difference. There are other medications that will take 2 weeks to a month to have maximum effect or to have a therapeutic effect. You also need to realize that sometimes medications cannot be started at a therapeutic dose because clients need to adapt to the medication to avoid side effects. So think, for example, of mood stabilizers like lithium. You usually start at an under therapeutic dose to make sure that there's no toxicity or anything like that, and then you increase the medication gradually. So it takes a time just to go to a therapeutic dose. SSRI is the same way. Psychiatrists tend to start it at an under therapeutic dose or a minimal therapeutic dose, and then they have a lot of room to grow before you can see any effects of the medication. Some medications like benzodiazepines that have a simpler mechanism of action might work immediately, right? If you've ever taken like an Ativan or some sort of benzodiazepine for an airplane flight, for example, it works, and then it goes away and it doesn't work anymore. It's a much more simple mechanism of action, and those are they work more immediately, and also we'll talk about more about they create dependence, and you need more of it to have the same effect. So they're not, most people doesn't use benzodiazepines long term because of that. And then, like I said before, psychotherapy and bottom-up interventions, which are basically experiential therapies, are two of the other things that will help create the new neural pathways. So medication helps with the transmission, but the medication does not create new neural pathways per se. All right. How do psychiatric drugs work? All right, let's start with antidepressants. Let's also know, like, it's important to know that antidepressants are not only prescribed again to treat depression, but they're also prescribed to treat other conditions like anxiety, pain, insomnia. And that's important because neurotransmitters, the same neurotransmitter can work on many messaging paths. So that's important to know. Like, sometimes I have clients be like, but I just can't sleep. Why are they prescribing me an antidepressant? Because the psychiatrist has done an assessment, and it's likely that your insomnia is related to a serotonin deficiency in the intersynaptic space. And if it's not, you'll find out because you'll take it and you'll still not be able to sleep, and then we'll try something else. But that's there's actually a lot of work recently of antidepressants, like I don't want to say the wrong one, but I think Paxil, especially Cymbalta, it's another one that work very well on chronic pain for patients, because again, serotonin, which is a feel-good transmitter, will also help you feel good when there is like chronic nerve pain as part of your condition. So there's more than one use for antidepressants. Commonly prescribed types of antidepressants, we've talked a lot about the SSRIs. Let's remember, they keep the serotonin in the synaptic space so that transmission can happen. The SNRIs do kind of the same, but they have two different kinds of votes. They have votes for the serotonin, and they have votes for norepinephrine. That will be your Effexor, your Paxil, your second sort of trial medications for depression. And they, although serotonin is the first sort of neurotransmitter that transmits feel-good messages, norepinephrine is a neurotransmitter that can potentiate or make the message clearer. Although not the primary messenger, it helps serotonin do its job, sort of makes the message clearer for serotonin. And the norepinephrine dopamine reuptake inhibitors, or NDRIs, are things like trazodone, Restorial, things like that. And again, those are pretty good for sleep, but they do have, they're primarily antidepressants as well. Antidepressant medications especially take a very long time to work, usually 4 to 8 weeks. And sometimes, especially with younger people, adolescents and young adults, there is sort of a paradoxical effect with antidepressants that we, practitioners and the public in general should be aware of. Not so much. I mean, most of you have adult children, so your children are likely not to have this side effect. But I would say the most severe side effect of taking an antidepressant is developing suicidal ideation. And that happens especially in adolescents. But you can observe sometimes sleep, appetite, energy, or concentration changes, which is what happens with depression anyway, especially at the beginning of using an antidepressant and getting used to that. So again, I wouldn't recommend necessarily, but because I have low appetite or my energy has changed, that I automatically will stop my antidepressant. But I would observe, I would see if like a higher dose or a lower dose has a better effect, and I will probably run the course of the 4 to 8 weeks before I decide that this is not working. But it's hard, and that's when the conversations are happening all the time, especially when someone is being initiated in a medication. Okay, anti-anxiety medications, and there are a bunch of anti-anxiety medications, but if you see the little drawing here, most of anti-anxiety medications are basically modifying the GABA receptors so that they slow down the anxiety message. So they reduce the symptoms of anxiety, such as panic attacks and extreme fear and worry. And for panic attacks and this kind of like anxiety attacks, the best medication, quite frankly, is a benzodiazepine. It's quick, stops the panic attack, and then you can, engage in therapy and work through your fear or whatever caused this severe anxiety. Other anti-anxiety medications are actually SSRIs. The neurotransmitter serotonin also works very well in, again, transmits well-being messages, so works very well on managing anxiety. It's a much better choice with chronic anxiety, generalized anxiety disorder, PTSD, anxiety that is more chronic and not necessarily a like one-time anxiety or a, benzodiazepines will probably be chosen for, again, panic attacks or specific phobias. If I'm going to go into an airplane again, I just need to make it to my destination. I'm going to be okay once I'm not in the airplane. But if you think about PTSD or OCD or generalized anxiety disorder, your symptoms are more widespread and would happen even with no trigger. So SSRIs are much better in terms of managing that kind of anxiety. SNRIs, again, second tier medication. When serotonin itself doesn't do the job, norepinephrine will help serotonin do the job. Benzodiazepines, one thing that you need to be aware of, there are different kind of lifetimes on the body for benzodiazepines. So a short-acting medication probably will take care of the problem sooner, but it also gets out your system sooner. And then if the situation has not been avoided yet, the symptoms will recur. There is other medication, other benzodiazepines that have a long life, and those are usually preferred in most situations because they might not act as soon as immediately as a benzodiazepines with a short life, but they stay longer, and you come off in a much nicer, gentle way. It's not in my system anymore, and now I need more. So there is also the least, because they're like long-acting and least aggressive in terms of leaving your body, the risk for dependency is a little lower. The main problem with benzodiazepines is really that if you use them regularly, they just don't work as well. They stop doing what they did before, and that creates dependence. And I know, not necessarily addiction. It's just like it just doesn't work anymore. You need more to get the same effect, and then you need more. If someone is in benzodiazepines long term, the recommendation in general is that if they're going to taper, they taper very, very slowly, months a month sometimes, or that the person stays at a low dose just for maintenance, because it's really hard to come off them And again, the brain has created dependence, and it's think about brain homeostasis. Brain homeostasis has changed, and now brain homeostasis for that person is with a certain amount of benzodiazepine at baseline. So it's taking you off that benzodiazepine. Sometimes it's just messing with brain homeostasis, and again, at a residential level of care, we can probably do that because we have time to do it. Doing it in an outpatient level of care, it's sometimes very difficult. So like, again, I've had parents before asking me, well, why is the psychiatrist not taking my family member off this, benzodiazepine medication, or, how long is it going to take? And my answer is usually takes a while, a long time. And a cautious psychiatrist might reduce that medication by 0.5 at a time, just to make sure that there's no change to the homeostasis again. Other medications used to treat anxiety are beta blockers. Beta blockers are, if you have high blood pressure or heart palpitations, you probably have been prescribed a beta blocker. And they basically slow down your heart so that you don't have tachycardia. If you have atrial fibrillation, you might be prescribed a beta blocker so that your heart doesn't go too fast. That's how they help anxiety, right? If your heart doesn't go too fast, you're not going to have that symptom of anxiety. You're not going to feel that you are having an anxiety attack because your heart can just not go that fast. So it's a very simple mechanism, and actually not so much related to neurotransmitters, but just, it manages like your heart rate. Antihistamines are what you take for allergies, like Benadryl. There are other antihistamines that are used mostly for psychiatric purposes, like Vistaril, for example, or Atrax. They're antihistamines, and they're sedating, basically. Like if you take a Benadryl, you're going to go to bed and you're going to sleep well. So if they're sedating, you're not going to feel that anxious. But again, a much simpler mechanism than a psychiatric medication. And Buspar or buspirone is another commonly prescribed anxiety medication, and this is not a benzodiazepine. It's not addictive, and it's also mostly sedating. So it takes the edge off, and it works. When used or prescribed at hospitals and residential facilities, it's mostly used as a PRN. If somebody's having a hard time, they take a Buspar, and it might take the edge off. And it's not as sedating as the antihistamines. If you take a Benadryl, you're going to bed, and sometimes clients don't want to sleep every time they're anxious. So Buspar might work better in that sense. All right, let's go to the next. Okay, stimulants. Again, we're focusing on symptoms. We're not focusing on diagnosis, right? Because when you think of stimulants, you think ADHD. Stimulants are prescribed basically for alertness and focus, regardless of diagnosis. People that has, for example, severe sleep disorders, they wake up, they're groggy, they can't focus, they can concentrate, and stimulant might be prescribed for that sleep disorder so that the person can function the next day. Of course, they're prescribed for ADHD, and if someone really has ADHD, it will improve their functioning, and it will not have stimulant effects. In other words, you won't necessarily see someone that has ADHD bouncing off the walls because they took an stimulant medication. There's, again, safe to take under healthcare provider supervision, and when they're used as directed. They do have an addictive quality to them, and there's a lot of press and a lot of documentaries and things like that about stimulants being abused, especially by college kids. Again, it increases focus and alertness, and if you spend the whole night out and you go to sleep and you need to be awake the next day, that will be probably what you choose to do if you want to daze your way out. So that's the danger of a stimulant. But if a kid really has ADHD, it is helpful, and it is a recommended medication. I guess my word of caution would be, if you have a young adult on stimulants, just again, a lot of education about compliance, because with compliance, misuse, it's likely not happening, because if you have, again, ADHD, my house is super noisy today. I do apologize. My dog that is barking is deaf, so it'll be useless to talk to her because she won't hear. Sorry about that. Hopefully she'll stop soon. So anyway, compliance with the stimulants guarantees not, it decreases the chances of misuse, and be sure that if someone has ADHD, there'll be no high with the stimulant. It just helps with focus and concentration. Okay, and then we have the antipsychotic medication, and look at the at the neural pathways that are affected by the antipsychotic medication. That's important to know, especially for the next session. None of these locations in your brain are part of your prefrontal cortex or your frontal cortex, which means that psychotic symptoms, as well as anxiety symptoms and other symptoms, live mostly on your primitive brain. And now, again, this will make more sense the next time we have the sort of webinar about therapeutic interventions. But that's important, because when you think about creating new neural pathways, we're basically thinking about bypassing our primitive brain and helping the client, helping ourselves use more of our newer brain, our thinking brain, so that better decisions can be made, thoughts can be disputed, change can happen. It is very difficult to change what our primitive brain thinks. You know, that's called the lizard brain, or the reactive brain. That's the fight and flight brain. When you activate fight and flight, you activate fight or flight. It's very difficult to tell your brain not to do its thing when you're talking to the primitive brain. So in that sense, it's really important also to not only to address these disorders with medications, but to address them with creating new neural pathways and that's done with mostly therapeutic interventions. Again, antipsychotics are typically used to treat psychosis, but not exclusively used to treat psychosis. Do not be surprised if your family member with depression or anxiety is prescribed an antipsychotic to potentiate the effect of the antidepressant. That doesn't mean your family member is psychotic. That just means that that antidepressant needs a little boost. Psychosis, again, do not think so much about the diagnosis. There are different causes of psychosis. They can be drug use, it can be a mood disorder, it can be a primary thought disorder. Sometimes PTSD has psychotic symptoms as well. So when someone says, I'm prescribing an antipsychotic, don't just, like, you know, a lot of people is like, oh my God, do you mean my family member has schizophrenia? And the answer is maybe. And even if they do, antipsychotics are the way to address that condition. But you know, your family member can have depression, PTSD, anxiety, a mood disorder. Antipsychotics are used for all those conditions. Antipsychotics might not get rid of all symptoms completely, and that's also important to note. They might just stop the person from being bothered by them so that they can live their life the way they want to live it. And that's important, and that in combination with especially CBT therapy for psychosis can help the person function really, really well in spite of the psychotic illness. So by minimizing the psychotic symptoms with, again, at the neurotransmitter level, and then by learning techniques to put less value to this internal stimulus, to learn to question this internal stimulus. You might have someone that might be still having some psychosis, but is able to dispute these psychotic symptoms successfully and live a fairly normal life, except for the fact that they take medications and they use their skills every day. But again, that would not be different than being depressed or being anxious. You know, we all have to, if we have any of those conditions, have to do the same thing, take medication and, you know, use our skills daily. There is always a possible risk of relapse in the future. And that's mostly, I would say, for two reasons. Most medications, this is not exclusive to antipsychotics, but most medications change their effectiveness through life. So you might have, and just a personal example, my daughter actually suffers from OCD, which is different than antipsychotic, but she was like, responded beautifully to Luvox from middle school until her second year of college. Second year of college, Luvox did nothing for her. She had to change her medication, and actually she got prescribed another SSRI and an antipsychotic to manage symptoms, and she did very well with that. But just to give you an example, that sometimes it has nothing to do with anything. Even the most compliant of clients might have a change on age, like was the case of my kid. You know, they might have a change of weight, they might get pregnant, they might, you know, get another physical condition that affects how neurotransmission happens. You know, things happen. We grow up, there's different changes in life. So the antipsychotic that worked 5 years ago, especially when you have a young adult, might not work, you know, later. So if someone started taking antipsychotics at age 18 and that antipsychotic did well for them for a little while, let's say until they're 25, and now they're 25 and you're like, why is the antipsychotic not working anymore? Likely because they're 25 and, you know, things need to be revised. So it's not, I guess what I'm trying to say is not a big deal. Sometimes they just stop working because of changes in the body. The other reason why there is a risk for relapse is because antipsychotics do have side effects, and as I explained before, there is the Parkinsonian effects, which are very annoying, and you know, clients don't like them. So it's paying attention to that and minimizing those is important. And newly second generation or new antipsychotics, Risperdal, Abilify, Seroquel, Zyprexa, sometimes have metabolic effects, and that basically means that they cause weight gain, and you know, especially young people might not like that. So paying attention to that, and again, holistic approach, right? If I know that I'm taking an antipsychotic that might have metabolic effects, making sure that there's fitness included in sort of the structure that that person has in their life, that there's like good nutrition, you know, that, and they're paying attention to metabolic symptoms to address this side effect early on, so that compliance can be maximized. And as I told you before, what dopamine does with antipsychotics do basically is they close the lock, put tape on the lock, so it reduces the flow of the messages that dopamine carries because the key doesn't go in anymore, and slows down that brain so that that brain can think clear. And these are your mood stabilizers. Mood stabilizers also work in the GABA systems. So similar than the benzodiazepines they use with the same neurotransmitters. This is another example of how neurotransmitters transmit different messages. That's the deaf dog again. Sorry, she doesn't hear anything but barks at the ears. So anyway, in this case, mood stabilizers, and when we talk about mood stabilizers, we're talking about valproic acid or Depakote and lithium primarily. They both inhibit the presynaptic discharge of GABA messengers. So instead of changing the receptor, like benzodiazepine does, basically valproic acid or lithium stops the first neuron, the neuron that's transferring the message, from putting too much GABA in the synaptic space. As I said, mood stabilizers are typically used for mood disorders, bipolar illness, and other mood disorders. Lithium is approved for the treatment of mania, and is also approved for the treatment of suicidal ideation in the context of bipolar illness. So, interestingly, with lithium, there are a lot of studies about families of lithium responders, which is good to know. And sometimes, bipolar illness is transmitted through generations. So if you have, for example, an older family member, let's say dad is doing well on lithium and has bipolar illness, and son starts showing signs of bipolar illness, that's important information to give the psychiatrist, because likely that psychiatrist is going to try lithiums, because that family might be a family of good lithium responders. If there is a certain genetic predisposition to respond to lithium as a mood stabilizer. Other than that, the most common medications used for mood stabilization are anticonvulsants, actually. I've had some people ask me, well, why is my family member on an anti-seizure medication? And the answer is because probably that was the best option to address their mood disorder. Yes, valproic acid, Depakote, is an anti-seizure medication, but it's also a very good mood stabilizer. And for people that don't respond to lithium, it's a good option. There are other anticonvulsant medications that work, maybe not as well, but for some cases will work. For example, lamotrigine is another mood stabilizer used primarily for bipolar 2, which means that it's not very good for mania, but it's good for mood instability or mood fluctuations. So when someone is diagnosed with bipolar 2, they go in between manic and depressive episodes, but they never really develop a full manic episode. So mood stabilization works pretty well with lamotrigine. There's Topomax, prescribed sometimes for mood stabilization for atypical reasons, like people with borderline personality disorder sometimes respond very well to Topomax, and I mean, borderline personality disorder is associated with mood dysregulation. People with eating disorders sometimes respond well to Topomax as well. And one of the things that, another reason why Topomax might be used is because some of these medications, or in combination with an antipsychotic, they also cause weight gain, and Topomax doesn't. So that's a good option for someone concerned about diabetes, for example, or something like that. So that's that on mood stabilizers. And okay, so we're good on time. We have 10 minutes. I'm gonna send you this. This is a video developed by NAMI. It's about an 8-minute video about psychotropic medications and how to talk to your family members about psychotropic medications. We don't have enough time to play it if we wanna have some sort of a conversation, but it's a good resource. And again, I'll be sending this to you so you can watch it. I'm also adding a couple of other written material in for your review. But recovery and support, and again, I am drilling this tonight, so I do want to talk about that. There's a bunch of studies that are fairly recent that recommend, again, coordinated specialty care or a holistic approach to the treatment of mental illness. 4 recent studies show that clients that participated in programs with coordinated specialty care had higher global functioning. That means their independent functioning was better, greater likelihood of being employed or in a school, which is related functioning as well, better quality of life, and lower risk for relapse. Because again, medications are a very good tool and certainly make life easier in terms of like transmitting the message, but the other therapeutic interventions are the ones that make the message possible. That's the takeaway from tonight, if anything. And coordinated specialty care provided a collaborative, shared decision-making approach that incorporates family involvement. That's you guys, and that's why we're doing this education, and that's why we have family meetings, and that's why we welcome you as part of the team. Individual resilience training. That means a lot of the work that we do with our clients is sometimes accepting your illness, and how do we build a meaningful life accepting that illness. Supported employment and education, which is another thing that we do, especially on our step down levels. And that might just be, encouragement to engage in this task, seeking employment, writing my resume, practicing skills to be employable. That sometimes becomes very difficult or threatening for our family members, especially when they've been through a lot through their illness. And individualized medication treatment, because again, cookie cutter approaches as to like this medication is for schizophrenia or this medication is for depression, it's really not going to work, because like we've been looking through this, medications they're not for diagnosis, they're for symptoms. So again, all these resources will be on the package that I sent to you. And that is I am going to stop sharing, and I think when I have Deb did it. The video is in there already for whoever asked for it. All right, so I think I am, at least you're ready to ask your question. I am opening this for discussion. If you have any questions or any concerns, please feel free to raise your hand or just talk. Yes, go ahead.
I just wanted to have the video too.
Oh, it's currently in the chat, and then I'm gonna it's in the chat. So if you go into the chat, Deborah just downloaded the link for the video there.
Oh, you click on it or something?
Yep, you click on it.
And then it will start playing right now?
Yes.
And it will still be there when you're done?
I can actually email it to you if it's not there.
That'd be nice. That'd be really nice. Thanks.
I will do that.
Thanks.
All right.
Thanks.
Any other questions? Let's see. Oh, no questions. Oh, there's Bailey again. Sorry, she's not a very good coworker. So a couple of other things that I can say before we go. If I thanks so much for your kind words to everyone that is saying thank you on the chat. It is I hope informative and opens your eyes to how things work, the approaches that we have for our clients, and also even if it's not us, right? Like the other thing that I love to do is like when you go to treatment anytime after this, if you're no longer in class, those are the things to look for in treatment. A coordinated approach that has a medication management approach, but also a therapeutic approach. Alone, nothing works. In combination with these multiple sort of facets of treatment, it's how you get the best results for your family members. So when you're like interviewing programs, when you're like trying to find the best approach, outpatient, inpatient, always look for all these things being part of what is offered. And encourage your family members to have that kind of approach to their care. We do try to do this education with them as well. Again, I love having a blackboard and showing them how like neurotransmitters work when I do this class with them. But it changes their perspective in terms of, why am I taking medications? and what are the limitations of those medications, and what do I have to do in terms of my own work to instill change. So I'm not sure if anyone else has any. Oh, Anita, you have your hand raised. Go ahead.
Hi, can you hear me?
Yes.
Okay, my son was diagnosed with ADHD and was prescribed stimulants. And then once he was diagnosed with psychosis, of course, he was taken off the stimulants and prescribed antipsychotics, but he still has impulsivity issues. So just wanted to understand what it means now that he has dopamine blockers, right? Is that?
Yes, yeah, that's what. So it'd be hard for me to tell you exactly what's going on with your son. You know, it had to be a complete assessment. But again, this is where psychiatrists do cost-benefit assessment when they prescribe medications. Polypharmacy is never something that a psychiatrist will want to do. So a lot of medications that affect similar neural pathways is never a good idea, and sometimes necessary, but I would say most psychiatrists will try not to do that first. You know, and impulsivity again can be, and also thing that we reviewed today is like you know, medication does not necessarily work 100% for some people. So medication, it's like antipsychotics might not be enough for your son to address all his symptoms. So the question to ask the psychiatrist is really, is there anything that can be done either medication-wise or therapeutic or therapy-wise to address that impulsivity, right? Because then those antipsychotics might be doing the best they can do.
Got it. Okay, thank you so much.
No problem. Any other questions? All right. Well, it's time. We made it through the hour. I will be sending all these materials to you guys. I would be sending the link via email probably as soon as we finish this talk, and hope to see you again. The next installment will be actually on therapeutic intervention, so it'll be fun. These are probably my most fun webinars to do. This one and the next one I do enjoy, so I hope to see you soon. Bye.